stroke of acute decompensated heart failure. Those were the patients, they had heart failure earlier, they are admitted with acute decompensation. Now we are talking in patients with de novo heart failure, hospitalized patients. So this is again in this era of evidence, without study we cannot say anything. There is the global report accepted and prevent study where it was seen 44% had de novo heart failure, here 66% were having de novo heart failure. Further found this sacubitril valsartan keeps de novo heart failure reduced ejection fraction patients out of hospital and helps them live longer. So if you start in those patients sacubitril valsartan, they remain out of that, means they did not need hospitalization. So there is significant lower incidence of composite of CV death and heart failure rehospitalization in de novo hospitalized patients with reduced ejection fraction if sacubitril valsartan started. So first admission, you start sacubitril valsartan, rehospitalization less and death is less. This is so the transition study. Yes, the same it has been seen. It came out European heart failure trial, heart failure journal, transition study, where they found the primary endpoint was to assess the tolerability of treatment in the proportion of patients who achieved the target dose of sacubitril valsartan after 10 weeks of randomization. A reversal of remodeling was noted in this patient. Sacubitril valsartan improves echocardiographic parameters of heart failure reduced ejection fraction. This is noted in real world scenario. This is also reported in this data study. Here you see there is sacubitril valsartan improved cardiac remodeling pump function more effectively compared to ACE-ARB in de novo hospitalized patients with heart failure reduced ejection fraction. Here you can see also HS troponin T, high sensitive troponin T, what was the effect of sacubitril valsartan. So significant reduction in high sensitive troponin T concentration with sacubitril valsartan in de novo hospital patients with heart failure. That means not only it improves survival, improve ejection fraction, improve quality of life, it also reduces the myocardial damage. In this study, it was seen the de novo heart failure is deep blue and prior heart failure reduced ejection fraction is light blue. More de novo than prior CHF patients achieved target dose at 10 weeks. So transition study results, first line initiation of sacubitril valsartan in de novo heart failure reduced ejection fraction alongside the initiation of other guideline directed therapies is feasible and is associated with a better risk benefit profile than in patients with prior heart failure reduced ejection fraction. Early intervention with sacubitril valsartan should be considered to delay the disease progression in patients with de novo heart failure with reduced ejection fraction. 2021 update of ESC update on heart failure, 2021 update to the 2017 ACEI expert consensus decision pathway on optimizing the heart failure treatment was published. What it shows, this is also an important slide. If you can concentrate, this gives the treatment algorithm provided by ACEI in 2021. Of course, this is just changed now in 2022. At that time, they told you start ARNI, beta blocker, and MRA is a foundational treatment from the very beginning if the patient is tolerating. So sacubitril valsartan or ARNI, beta blocker, and MRA. You see here all three things you can start, and after that you assess the patient. For patients with eGFR more than 30, if there is you can give other treatment. If patient still eGFR criteria, SGLT2 inhibitor can be given. If patient remain in heart failure, diuretic further can be given. For persistently symptomatic black patients, hydralazine isosorbide dilated combination can be given. If heart rate remains 70 or more, then evaporating can be given. This is what they told at that time. So clinicians should aim to achieve optimal GDMT within 3 to 6 months of initiation of diagnosis. But the ESC 2021 told ARNI may be considered as a first-line therapy instead of ACE inhibitor ARB in heart patients. But ACEI told in 2022, same thing was told by ESC in 2021. So initiation of ARNI is in hospitalized stable patients with heart or reduced dysfunction, including those who are on ACE inhibitor ARB naïve, is safe and may be considered. This thing is again told by ACEI in 2022. That with this slide we have seen earlier, where ACEI says you go with ARNI, if intolerant to ARNI or ARNI treatment not feasible, go to ACE inhibitor. If ARNI and ACE inhibitor are not feasible, go to ARB.